Nsaids and other pain medications, what you need to know for your patients. Regardless of our focus on a conservative, non-drug, non-surgical approach to patient management, patients often either take over-the-counter pain medications or have had medication prescribed by an MD for their pain. Here's an example for prescription in primary care for low back pain. We can see that Nsaids, muscle relaxants, and Acetaminophen are prescribed in 80% of cases. Specifically, 69% of patients were prescribed Nsaids, 35% muscle relaxants, and 4% acetaminophen, with only 20% not prescribed a medication. It is crucial then that we understand what these medications are, their general proposed mechanisms of action, concerns, and some potential alternatives. Here are the important questions that we will attempt to answer using the literature. What are the pathways by which inflammation and pain occur that are affected by medications and their alternatives? What are the most common medications? What are the concerns about these medications? And what do national guidelines, RCTs, and systematic reviews say regarding the evidence for their use? Let's start with a review of one of the pathways for eventual inflammation. Arachidonic acid, an omega-6 fatty acid, is converted to a group of metabolites called eicosanoids. One pathway is to convert arachidonic acid to prostanoids through the action of an important enzyme called cyclooxygenase, or COX. These prostanoids include the inflammatory prostaglandins, thromboxanes, and prostacyclins. Another conversion of arachidonic acid by lipoxygenase, or the LOX enzyme, is to leukotrienes that are responsible for some of the inflammatory aspects of asthma and allergic reactions. A balance occurs through competition with the COX enzyme. This is between arachidonic acid and omega-3 fatty acids, represented here by DHA and EPA. Anti-inflammatory omega-3 fatty acids are found in green vegetables, most fish, wild game, and grass-fed meat. Metabolites of DHA and EPA are a different series of prostaglandins and thromboxanes that are either less inflammatory or anti-inflammatory compared to the metabolites of arachidonic acid, which are generally inflammatory. So, how do medications affect or take advantage of these pathways? Well, usually through competition or blocking. For example, corticosteroids inhibit phospholipase A2, which inhibits arachidonic acid release from the phospholipids in the cell membrane. Aspirin, nonsteroidal anti-inflammatories, and COX inhibitors block the cyclooxygenase enzyme that converts arachidonic acid to prostaglandin E2, thereby decreasing or blocking inflammation. Additionally, non-drug ingestibles have similar actions, such as turmeric, ginger, bioflavonoids, and boswellia. This visual is simply to remind us that these are very complex, often overlapping processes, and that for clinical purposes we are having to generalize. There are many other components that influence these processes. One example are cell signaling molecules which stimulate genes to induce the expression of the COX enzyme. Molecules such as nuclear factor kappa light chain enhancer of activated B cells, or NF-kappa B, are important and can be influenced. Green tea, polyphenols, resveratrol from red wine, vitamins C and E, curcumin, and glutathione reduce the activation of NF-kappa B. Aspirin, NSAIDs, and corticosteroids inhibit binding of cell signaling molecules such as NF-kappa B, which reduces inflammation. It is possible that carotenoids and flavonoids also have similar actions. Without these inhibitors, NF-kappa activation induces COX-2 activation, leading to inflammation. The expression of the coding gene for COX-2 for the production of prostaglandins is transcriptionally regulated by NF-kappa B. It's in the cytoplasm and it's bound to its inhibitor. Free radicals release NF-kappa B from the inhibitor, which then moves into the nucleus to activate genes responsible for COX-2 activation and prostaglandin formation. There are generally three types of medications that are used in the management of pain, including analgesics, anti-inflammatory medications, and muscle relaxants. In addition are some adjunctive medications that often have sedative or antidepressant effects. It's important to note that some medications have elements of 2 or 3 of these actions, or are combined to achieve such an effect. Let's start with medications whose main function is pain relief, analgesics. They are divided into 2 general categories of opioids and non-opioids. The opioids are chemically based on morphine and include familiar drugs such as oxycodone and methadone. These were previously called narcotics. Non-opioid medications are not related to morphine and for that reason are not of concern regarding physical dependency. However, they are not as effective for severe sharp pain. Unlike the opioids, the neurological effects often involve both the peripheral and central nervous system. You may think that opioids are not often prescribed. However, either alone or in combination, their use is widespread. This study from the University of Pittsburgh in 2001 indicated that of the 56% of patients with a pharmacy claim for analgesics for low back pain, 33% were opioids, 26% were a combination of opioids and Nsaids, and 9% were other analgesics. Most of the opioid use was for short-term only. Now the anti-inflammatory medications. They're divided generally into steroids and non-steroidal anti-inflammatory medications. The steroids include prednisone and methylprednisolone, hydrocortisone, and betamethasone. NSAIDs are represented by generally three categories of salicylates, such as aspirin, traditional NSAIDs, and specific COX-2 inhibitors. Other than the obvious prescription of corticosteroids for rheumatoid conditions and asthma, chiropractors often see patients who are prescribed what is called a Medrol dose pack. So what is this? This is a steroid, methylprednisolone. The dose pack is not a pack applied to the patient's back. The pack is actually a card with 21 4 milligram pills. The intention is to start with a maximum dose and gradually taper off so that initially 6 pills are taken and then 1 less pill each day until finished. For patients who simply do not respond to treatment and are in severe pain, this approach is commonly used and chiropractors often refer patients for this intervention. Given the majority of patients take over-the-counter or prescribed NSAIDs, let's move into a description of how NSAIDs work. There are different isoenzymes of the COX enzyme. COX-1 is referred to as constitutive because it is found in most cells, whereas COX-2 is considered inducible because it mainly occurs in reaction to inflammation and is found in activated macrophages. The non-selective COX inhibitors block both 1 and 2 isoenzymes. These include aspirin and most NSAIDs. Selective COX inhibitors block the COX-2 isoenzyme. This is represented by celecoxib or Celebrex. Note that the function of these enzymes is not necessarily bad and often essential to proper function, so that their blockade carries with it adverse reactions. For example, the most common problem is interfering with their role in GI protection, especially the lining of the stomach, but also for renal blood flow and for clotting through platelet aggregation. As a result, the most common problems are gastric irritation and bleeding, and because of an increase of thromboxane, with an inhibition of prostacyclin by COX-2 inhibition, there is an increase in atherothrombosis or clot formation. This leads to an increase in heart attack and stroke. Additionally affected are the kidneys, with an increased risk for renal failure. Here's a list of common NSAIDs. Note that ibuprofen, represented by Advil and Motrin, and naproxen, represented here by Aleve, are the most popular over-the-counter meds, and that they have both analgesic and antipyretic effects, but that the dosing for this is different than the anti-inflammatory dosing, which is generally higher. Also a reminder that QID stands for 4 times per day, TID 3 times per day, BID 2 times per day, and QD is once a day. You can see the problem immediately if QD and QID are misinterpreted or misread. Why don't we see acetaminophen most commonly sold as Tylenol here? Because it is in a class all its own, which we will discuss separately. Note that not all synthetic NSAIDs are used for all 3 effects of reducing pain, fever, and inflammation. In fact, we can see here that the one COX-2 inhibitor on the market, Celebrex, is dosed only for anti-inflammatory effects. So what about combination drugs that you see your patients prescribed? I'm sure many of these are familiar, such as Vicodin, Percodan, Percocet, Tylenol with codeine, Darvocet, and Darvan. What you can see is that they are mainly represented by combinations of either aspirin or acetaminophen and either hydrocodone or oxycodone. In other words, an NSAID with an opioid. The concerns then are the gastric and cardiovascular risk with NSAIDs and acetaminophen, and the dependency and narcotic effects of the opioids. Given acetaminophen is so widely used either alone or in combination, and both over-the-counter and prescribed, it's important to understand its differences from Nsaids. Technically, it's part of aniline analgesics and is known more for its antipyretic and some analgesic effects, but not as an anti-inflammatory. Unfortunately, acetaminophen has over the past few years been investigated for a host of possible serious adverse effects. Among these are an associated risk for asthma, hypertension, elevation of liver enzymes, and hearing loss. Let's look first at the association with asthma. So why would this be? It seems almost counterintuitive. One possible theory is that it depletes needed glutathione in airway mucosa that may cause the risk of damage from oxidative stress. The two concerns are that acetaminophen increases airway inflammation in those that have asthma or predisposed to asthma, or the individuals are more likely to develop asthma if exposed to acetaminophen in utero. Use of acetaminophen has been associated with an increased risk of asthma that is about 2.87 times normal. Asthma symptoms occur in 38% of 13 to 14-year-olds who used acetaminophen. Also found was an association to current wheeze or asthma symptoms in over 40% of individuals. How can this association be established given the wide variety of possible culprits? There was a rapid rise in asthma prevalence in the 1980s when acetaminophen was being substituted for aspirin for children. This increase leveled off in the 1990s when acetaminophen became the standard. This leads to the plausible explanation that it was the acetaminophen because there were no other dramatic environmental changes that occurred during that same time. Also, for 36 countries, the per capita sales of acetaminophen can be used as a predictor for the prevalence of childhood wheezing. Another concern is liver damage. In 2011, the FDA issued a warning to limit the amount of acetaminophen to 325 milligrams per tablet or capsule and required a boxed warning highlighting a potential risk for severe liver injury. The caution is that for those taking more than the prescribed dose or more than 4 grams per day, liver damage is possible. Patients and doctors should also be vigilant about taking more than one acetaminophen product and avoiding alcohol while taking any acetaminophen-containing drug. Here's an example of a study that used a placebo control compared to those taking the maximum daily dose of Tylenol. Note that there was no increase in ALT in the placebo group, but that 33 to 44% of those taking Tylenol had 3 times the upper limit of ALT, with some patients having as high as 10 times the upper limit. Elevations returned to normal after discontinuing Tylenol, but this was for only a 2-week regimen. Another caution is that patients may not know they are taking acetaminophen because of the numerous abbreviations. Here are some examples. Although Nsaids have been associated with an increase in blood pressure, only recently has attention focused on acetaminophen. In a study published in 2010, it was found that for patients with coronary artery disease, there was a small increase in both systolic and diastolic pressure. Larger studies need to be conducted, though, to clearly establish this relationship. Let's move on to the Nsaids and some specific concerns in the literature. Ironically, it appears that the cardioprotective and stroke protective effect of low-dose aspirin may be compromised by taking ibuprofen. Here we see suggested timing to avoid this effect. Clearly, taking aspirin first 30 minutes before ibuprofen is a shorter lag time to be concerned about. One of the primary concerns with aspirin and Nsaids is the effect of decreasing the protection afforded by COX enzymes for the lining of the stomach and GI tract. In fact, as the prevalence of H. pylori decreases for all peptic ulcers, it's more likely that Nsaids will be the dominant cause of ulcers. Why? It appears that worldwide, improved hygiene has led to an independent reduction in H. pylori infection, independent of the treatment of ulcers with the newer regimen of a triple antibiotic approach. So, as the number of cases of H. pylori-caused ulcers decreases, the increased use of Nsaids will increase proportionately the number of peptic ulcers caused by their use. Another concern that many people are not aware of is that chronic use of aspirin, Nsaids, and acetaminophen can cause hearing loss. Look at the results of this study. 26,000 men were tracked every 2 years for 18 years. The percentages are comparisons to non-regular users of that medication. So, for example, men using aspirin regularly were 33% more likely to have hearing loss compared to those who did not. Now look at the relationship to age. For Nsaids and Acetaminophen, it is higher for those under 50, decreasing for those in the age group of 50 to 59, and half that for those 60 years and older. Most notable, though, are the percentages for those under 50. Hearing loss was 33% more likely for men using aspirin regularly, 61% for those using Nsaids regularly, and a whopping 99% for those using Acetaminophen regularly. Certainly, this is not an association that has gotten much attention until now, and you should remind your patients of this study if they use Nsaids or Acetaminophen medications regularly. Now, muscle relaxants. This is really the most heterogeneous group of medications that include antispasticity medications that are primarily used for upper motor neuron lesion spasticity, and antispasmodics that are then divided into benzodiazepines and non-benzodiazepines. The original benzodiazepine was Librium, marketed soon after was Valium. They're clearly known for their sedative effects. Benzodiazepines act primarily through augmenting the effects of GABA, which is a neurotransmitter with inhibitory effects within the central nervous system, including the limbic system and reticular formation. Like all medications in this discussion, there are many formulations, and many are not only oral but injectables. Clearly, not all are used as muscle relaxants for back pain. Included in the benzodiazepines are Halcion, Ativan, and Xanax, with each its own primary use, such as decreasing anxiety as a sedative for pain and some for anti-tremor and anticonvulsive effects. Some non-benzodiazepines, such as Lunesta, Sonata, and Ambien, are best known for their sleep induction properties. Here are some non-benzodiazepines used for muscle spasm you should be familiar with. Note that they do not relieve pain, but instead either reduce muscle spasm or are sedating. Here are some common side effects, including drowsiness, dizziness, and in some cases severe allergic reactions. But some, like Flexeril, may cause urinary retention in males, and soma may be habit-forming. Let's now briefly review recommendations based on clinical practice guidelines or systematic review findings. We'll see that the clinical practice guidelines, or CPGs, are different for different countries. Europe, Italy, and the U.S. CPG recommendations were that there was evidence for use, but only short-term. Belgium concluded that there was no evidence for their use or for aspirin. The U.S. CPG concluded there was insufficient evidence to estimate the effectiveness of aspirin. COX-2 inhibitors were recommended in the UK only if acetaminophen was not effective. Now the CPGs for use of muscle relaxants for chronic low back pain. Belgium, in a 2006 review, found only low-quality evidence to support the use of muscle relaxants in the management of chronic low back pain. The recommendation was that only short-term use should be considered. European guidelines in 2004 found strong evidence for support for benzodiazepines for chronic low back pain, but conflicting results for non-benzodiazepines. For the U.S. guidelines in 2007, there was no evidence generally for the use of muscle relaxants, but they found moderate benefit for benzodiazepines. Systematic review findings for the use of medication for chronic low back pain are interesting. Nsaids are more effective than placebo for low back pain without sciatica, but have more side effects. Nsaids are no more effective than placebo for low back pain with sciatica. Nsaids are effective for short-term relief of low back pain in general. Evidence is mixed about whether benzodiazepines are better compared to other muscle relaxants. Little is known about the non-drug alternatives. Here we see some suggested dosing for proteolytic enzymes, here represented by bromelain, bioflavonoids, and specific herbs or spices. These are taken for the proposed anti-inflammatory effects, yet the exact dosing and effectiveness are not fully substantiated. Other concerns are that bromelain should not be taken by individuals with peptic ulcer, systematic infection, or allergies to the source product, often pineapple. Also, the interactions of these substances may interfere with other medications with similar properties. Hopefully, this brief overview delineated for you the kinds of medications used for pain management, the mechanisms of their actions, some common concerns, and some alternatives. It's important to reflect on our role as chiropractors to be a patient advocate. This means that regardless of whether we prescribe medication, we must be aware of their effects, especially when having a discussion with our patients about alternatives and their benefits and risks.